collapse and expand the panel just to get it out of the way so that you can see the slideshow that we'll have going on behind it. Additionally, there's the option to raise your hand to request to be unmuted. We do mute everyone simply to handle the feedback, any type of thing, so that you can hear us clearly. Additionally, at the bottom, there is a chat box, so you can submit your questions or your comments via the questions box at the bottom, and will be available to answer those as we go through this process. Okay. Okay. And today, a few people will be speaking to you. First, Holly Hagel, PhD, is the director of the National SBIRT ATTC. Dr. Hagel has been actively working with providers since joining the Institute for Research, Education, and Training in Addictions in 2003, and she oversees all of the training and educational initiatives. Brett Harris, DRPH, is Project Evaluator of the federally funded New York State SBIRT Cooperative Agreement, which delivers SBIRT in STD clinics and tuberculosis chest centers in New York City. Then we have Tracy McPherson, PhD. She is a Senior Research Scientist at NORC at the University of Chicago. Over the past 13 years, McPherson has led initiatives supported by NIDA, CSAP, NHTSA, NHLBI, SAMHSA, and CDC. Okay, and at this point, I'm going to go through. We have some questions for the audience, just to get a feel for where our audience is coming from. So I'm going to take you through a few of these poll questions. I'll launch this one now. I'll read the question off to you, and then I'll wait till a good number of people have answered, and then we'll move along. Okay, the first, what is your current professional role? Options here are counselor, therapist, social worker, nurse, nurse practitioner, physician, program or unit administrator, university student or faculty, and then there is the option for other. For that other option, you can put that into the questions box just to give us that information, and we'll write that down separately. That'll give you a view of how attendees did answer. Okay. Next, we have which field do you represent? We have mental health, addictions, physical health, education, EAP. Going to move on to the third. Do you conduct SBIRT interventions? That is a yes or no. Moving along to number 4. Do you see your agency using SBIRT? Okay, and our final question. In which setting are you most likely to implement SBIRT? We have school or school-based health centers, juvenile justice settings, job placement programs, primary care, and community mental health. All right, great. And we do appreciate you taking the time to go through those questions for us. I do want to let you know we do record this session. We will be posting this to our website just to have it so others can view it later. At this time, I'm going to switch over to Dr. Hagel.
Thanks, Danielle.
Okay.
I'll be showing my screen here in a second. Did you switch it to me? I didn't get a box.
I did. Let me see if I can.
There we go. Okay. Well, thank you, everybody, for joining us today. I just want to reflect that those percentages for the polls that you saw just now is out of the 52 attendees that we have right now. And so it seems like we have a diversity of professions represented. Oops. Here we go. You see my screen now?
Yes.
Okay. And so we have a diversity of professions across, education, healthcare, nursing. But I did see that addictions was the largest profession that was represented from our selections. That many of you said you're not doing SBIRT yet, but you do want to do SBIRT, so you're on the right place. We're glad that you're here. And for those of you that are doing SBIRT, we can learn from you. You can share your experiences on subsequent learning communities, and there's always something we could be learning even if we're implementing something actively. And then the other thing I wanted to comment on about the polls is that it seemed to be that the highest percentage of places that you envisioned doing SBIRT, the setting was schools and primary cares, and some representation for juvenile justice. And after today's learning community session, we hope that you see, that there's some beginnings of an evidence base around, I don't know if Dr. Harris would agree, but we're beginning to build the science around and understand how screening, brief intervention, and referral to treatment for youth in different settings is having an effect. So that's really what we're here to learn about today. But I want to take a moment to tell you about the National SBIRT Addiction Technology Transfer Center. Here's our goal. We're funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to disseminate this timely public health model. And we like to say timely because we feel like, we're hitting some sort of sea change moment where our understanding of substance use is widening to include a public health model, and so we want to infuse these public health models in as many settings as we can so we can reach people, especially youth in this particular case, when they're ready to talk about their patterns of substance use. And we've been trying to do this as a national focus area on this topic through offering a variety of services in a product base that we call our suite of services. And some of those services are, we have a national registry of qualified SBIRT trainers, and it literally spans every state in the U.S., and you can search that registry just by clicking on your state or state you're interested in on our website. We have a monthly live webinar series on a variety of SBIRT topics. That's different than this. We're using webinar technology, but we're intending this to be a community of learners. So hopefully you'll be returning every other month to this community so we can share how we're implementing SBIRT in youth settings. But we have other topical webinars that you can find out about on our website. We also have a library of our recorded webinars, and we've been funded now over 2 years, so we have quite a selection in our library. And you can just watch those on YouTube at no cost. We also offer technical assistance and consultation at request, and I'll share our general email address. And we will talk to your organization or agency and see if your request can line up with something. Sometimes it's simple information, but sometimes it's more intensive technical assistance or training or coaching. but we're open to collaborating with groups and entities. We have a bunch of online resources that I'll show you in a second. Many of these are downloadable products that you could use. We're trying to make this easy for practitioners to implement SBIRT. So one of the things we've developed are toolkits for practice. All of this stuff is on our website. We've done some digital tours like shortcuts so that, we might take a document like the CDC Primary Care Guide on implementing SBIRT in primary care, or SBI for alcohol in primary care settings, and give you a 2 to 4 minute overview of what that product is. And that way you can decide if you want to go into that product more in depth, or maybe sit in a webinar and learn more about it. And then we have a pretty regular, probably once, maybe twice a month, depending on how much content we have, an electronic newsletter, and we announce all training events and other SBIRT-related materials. And we're also doing some storytelling. It's still a tried and true method of learning, and we do that through our I Read a Blog, our parent organization, and it really is telling stories about how SBIRT's applied in the real world. All of these and many, many more things can be found on our website. And our goal is to put it in one place. We connect with others who do SBIRT trainings and education so that people can get all the information they need in one place. And we have this conference coming up in June, so please visit our website, learn more about it. Registration is open. We're focusing, this is broad for adult and youth populations, but there's something for everybody. The novice SBIRT person, there's a track for SBIRT 101, and then for the experienced SBIRT people, we're going to look at more in-depth specific SBIRT topics. So visit our website to learn about our conference. But the main point I want you to know is all these resources are on our website, the ones I just went through. And then I wanted to highlight a great self-paced online course that we've done. We're very lucky to partner with Dr. Sharon Levy's group out of Boston and take a webinar that she did. She is one of the leading experts in the country on this topic of adolescents and how you could apply screening and brief intervention. And you can earn CEUs. If you don't want the CEUs, you just want the knowledge, you can just take the course and really get a full understanding how SBIRT can be applied to adolescents, and in particular why it's important during adolescent development that we're even talking about substance use. So what are the goals of this particular learning community? And this was in some of the registration material, but I wanted to highlight that we want to examine the application of SBIRT in a variety of settings. That's why we are interested in schools, primary care settings, job placement programs for youth. We're trying to, again, use this public health model to intervene with substance use no matter where people are in their pattern and history of use or where they are in society. And we want to create a community of providers who have this similar interest in implementing SBIRT for youth. And we also want you to share your experiences implementing SBIRT. We've taken the next 2 learning community times and crafted topics around them, but we're going towards wanting you guys to direct the learning, for you to identify the topics that we cover, or just talk to each other about implementation strategies. So what are some of the things we're going to offer as a community of learners? Well, we're going to have these bi-monthly online learning community meetings. And right now, the next 2 are topically based, and Dr. Harris will talk to you about those at the end of her presentation. But we want you guys to direct, the goal of the learning community going forward. So we'll send you little questions about, or open panels and polls to find out what you would like to examine going forward. We're also going to have one page on our website that has all the resources that we've specifically been identifying, and our recordings of this webinar, learning community sessions, and other resources, again, on our website. So we have that one place people can go to for information. And then finally, we would like to offer technical assistance, some support, implementation or coaching, even troubleshooting by request. And here's that email I mentioned to you all. You will get the slides at the end of this webinar session, and they'll be posted on our website. So, we will look at your request and we'll try to match it. If it's just information, we'll request, give you more information. But if it's something a little more intensive, and it matches our work plan, we're open to working with people and systems in particular who want to implement SBIRT for youth. And then my last slide before I turn it over to Dr. Brett Harris is really why I personally feel we should care about screening and intervening early for youth. I'm a middle-aged lady now, and so I really have that vantage point of looking backward a little bit. And it is true, I'm not the first person to say this statement, but science is solidifying our knowledge that adolescence is that last stop before adulthood. And we do know from 40 years of addiction research that it does have early onset, that people who end up having a diagnosed, substance use disorder have typically started around age 12 to 14. And, if we know the science is telling us that, we really have, as a society, the obligation to respond. And that's why I personally, and we as an SBIRT focus area, are committed to understanding how this could be applied in youth settings. And then this is just a study that really just highlights to me that we should be intervening wherever youth are. So this study talks about the most promising sites to identify youth needing but not receiving substance use treatment. These are not even the kids that might be using in a risky way or have, binge use of substances. These are kids who have an established pattern and probably need treatment. And they're not, there's a percent in hospitals. Some of them have other co-occurring issues. They may have juvenile delinquency problems. They may have mental health problems. But look at this, 96% of those students attend schools. So really, schools are a vital place in our society where we could be intervening on that last stop before adulthood early to help, have the healthiest, most well-adjusted adults that we can have in society. All right, that's my spiel. Let me hand it over to Dr. Harris. I'm just going to change the presenter, Brett. Hopefully you see the panel window. Thank you, guys.
Yes, can you see my screen?
Yep, it looks good.
Okay, great. Okay, so thank you everyone for joining, and I know some of us are coming from a pretty snowy area. It's pretty white where I am, so I'm glad to have you all here, and you must all be interested somewhat in implementing SBIRT in a youth setting. So, really the purpose here is to give you an overall picture, tell a story of where we are with the research for SBIRT, because SBIRT is an evidence-based practice for addressing risky substance use. So what do we mean by evidence-based practice? And we all need to develop a reason for implementing SBIRT, and whether we need to get grants for this or just have a real rationale for doing this. So my purpose is I'm going to give you a quick overview of where the research is for adults, and then focus most of the attention on specific research studies with adolescents, and then really what's going on now. How are adolescents are they being screened? Are they getting brief intervention? So for adults and alcohol, I'm not going to spend a lot of time on this. I'm just going to go over a couple of studies, and one of them is Fleming et al., and that found significant reductions in 7-day alcohol use, number of binge drinking episodes, and frequency of excessive drinking. So there was an impact of SBIRT on actual alcohol use, which was maintained over a 48-month period. It also found, as a result of the brief intervention, were some other outcomes, very important outcomes: fewer emergency department visits, fewer non-fatal injuries and hospitalizations, fewer arrests, and motor vehicle accidents. The other researchers found similar outcomes for alcohol. So you'll see that I put citations here, and they're all provided at the end of the slides, which you'll get access to later. Kainer et al. Performed a meta-analysis, so really the gold standard of studies, finding that those receiving brief intervention had lower alcohol consumption after 1 year than did the control group. And also cost savings have been found associated with SBIRT. Really, it's been a 4-to-1 return on investment. So the United States Preventative Service Task Force makes recommendations, for preventive services, and for alcohol use for adults, providing screening and counseling has ranked above that for even high blood pressure. So this ranking was given a grade B, which means that the service is recommended and that there's high certainty that the net benefit is moderate, or there is moderate certainty that the net benefit is moderate to substantial. Now for drugs, the findings are mixed, and just recently there were two articles that found that brief intervention does not decrease unhealthy drug use in primary care patients identified by screening. So this, created a big, stir up in the SBIRT field. The real issue here is that these were in specific settings and specific populations. That raises some questions, but also that this doesn't necessarily mean that SBIRT for drugs is not a good thing, because that is the efficacy of the screening and identifying patients and then giving them a chance to have referral to treatment is very important. Other studies, actually, it was more of an evaluation of SAMHSA-funded programs, found that brief interventions reduced drug use by almost 70% at 6-month follow-up. So the U.S. Preventative Service Task Force gives this an I rating, so there's insufficient evidence to assess the balance of benefits and harms. Now for adolescents, so this is also an I rating. Screening for drug use also received a grade I for adolescents, similar to that for adults. And the problem here is the lack of rigorous studies. There's not sufficient evidence. An issue with adolescent studies has been that it's very difficult to get students or get adolescents to participate in these projects, because in research, not only does the adolescent have to consent, but so does the parent. And also, there is a lot of dropout in these programs, and in terms of finding positive results. In adolescence, of course, there is just a natural increase in alcohol and drug use. So, of course, over time, it makes it difficult to find whether there was a decrease in use based on SBIRT. So I'm going to take you through specific studies, I tried to find studies that were in different settings to match who's on this call. And these settings and these studies, these are the most widely cited studies, and I put more information than usual on the slides so you have an idea of what the study is and what the intervention was. So I'm going to start with D'Amico's study called Project Chat, and this was in a community-based healthcare clinic in Los Angeles. So the population was adolescents, 12 to 18 years old. They were at risk. They were mostly Hispanic, Latino. And the intervention was a 15 to 20-minute motivational interview with a 1-month, 5 to 10-minute booster telephone call. So this is really, what we call a brief intervention, setting motivation to change, enhancing motivation to change, and making a plan. So what they found was that at 3-month follow-up, that the teens that were in the, the intervention group reported less marijuana use, lower perceived prevalence of marijuana use, meaning that they thought that, fewer of them thought that all of their friends were using it, and fewer friends actually reported who were using marijuana, and then they had lower intentions to use marijuana in the next 6 months. And of course, the question that gets raised here is that it was a small sample size. There were only 42. There was attrition in the study. Now, another pilot study was John Knight's group, and this was a motivational interview, and it was in medical practice and the adolescent substance abuse program at the children. So the population was 14 to 18-year-old patients, and this was a two sessions with a clinician 2 weeks apart. So once again, this is what we typically refer to in a brief intervention. We have assessment and feedback using the craft, identification of risks and problems, discussion of pros and cons of change, completion of structured change plan worksheet, and summary and follow-up plan. So at 3-month follow-up, participants showed less drug use, so it's most notably among the hard drug users, and then also reduction in driving while intoxicated or riding with an intoxicated driver. And here the limitation, again, is the small sample size, and there was difficulty with recruitment and attrition. So the sample size was only 22 people. Okay, so SBIRT in a continuation high school. Now, continuation high school, I put a note at the bottom. These are for students who cannot attend regular high schools for reasons such as conduct problems and drug use. So the setting was in 2 of these schools, and students were, it was in 3 morning classes at the mean age of 16. So the intervention was a 25-minute brief intervention used to establish rapport, agreeing upon a behavior to discuss, providing normative drug use feedback, discussing pros and cons, affirming capacity to change, and summarizing the session. So this was, there weren't really, it wasn't a big outcome study. So what they did find was that youth were willing to discuss their personal drug use and are satisfied with the brief intervention. And they did at 3 months report greater readiness to change their drug use. And once again, there was a small sample size, an N of 18. Now, Ed Bernstein's group did a study, what they also call a pilot study, though you can see there's a larger sample size here. This was screening and brief intervention for marijuana use in a pediatric emergency department. This was in an inner-city academic hospital. So the population was 14 to 21-year-olds not reporting risky alcohol use. This is really just to study marijuana. It was a 20 to 30-minute brief intervention delivered by peer educators, and these peer educators were age of 25 or under. And I'm not going to go over what the intervention was, but it was really, what we consider goes into a brief intervention following the brief negotiated interview that Ed Bernstein's group did work on. And the findings were that at 3 and 12-month follow-up, the youth in the intervention group were more likely to report abstinence, effort to cut back or quit using marijuana, and fewer days high. And what this group reports that this is a small pilot study, and they did not have enough power to show differences in risk behaviors and consequences, and they also did not attempt to quantify use. Now, I'm also going to present a couple of other studies here. This is an evaluation of a SAMHSA SBIRT program in New Mexico that implemented SBIRT in 13 school-based health centers. They had a total of 629 14 to 17-year-old students, and they used the brief intervention, specifically focusing on weighing the costs and benefits and increasing motivation to change. So at 6-month follow-up, students reported significant reductions in drug use and drinking to intoxication, but it did not differ by intensity of intervention, meaning that whether they received, one brief intervention, multiple brief interventions, or even brief treatment, the same findings existed. And of course, this was an evaluation, so there was no control group. Now, these next 2 slides are presenting variations on SBIRT, so it's not really, strictly the SBIRT model, but I wanted to introduce a couple of other settings, and one, straight in a school.
Okay, I think we may have lost audio. Okay, I think we may have lost Dr. Harris. Let me take just a second and see if we can get her back.
Hi, can you guys hear me?
Yes, we can.
Okay. Yeah, I'm sorry. I lost my phone disconnected. So, all right. So I'm just going to pick up where I left off. All right. So Now, I'm presenting some variations because we're specific studies on SBIRT per se. So I'm going to focus one here on a school. Ken Winters does a lot of work using Teen Intervene, which is a slightly, it takes the brief intervention with motivational interviewing, but it's a slightly longer and more intense intervention. So this study was from the Twin Cities metro area public school system, and the population were 13 to 17-year-olds. So these students were all identified by school officials as possible drug users. They were actually given a chemical health assessment, which is how they were identified. And most actually met the DSM-4 criteria for alcohol or cannabis use disorder. So Teen Intervene is, as I said, a longer, they have 60-minute sessions, and they also would bring the parents into the intervention for one session. So in this study, the active conditions had 2 60-minute brief interventions separated by 7 to 10 days. And one was adolescent only, and the other involved the parent, as I said. So the first 2 sessions were identical, but the one with the parent included it was a third 60-minute session. So at 6-month follow-up, the 2 intervention, the active conditions, 2 groups showed more reductions in alcohol and drug behaviors than the control group. So the 90-day alcohol and cannabis abstinence and absence of alcohol and cannabis abuse and dependent symptoms, and the group with the parents showed significantly better outcomes compared to the one with the adolescent-only group on all but alcohol abstinence. So you can see, involving the parent is a great, idea, and it's very important, especially with the higher-end users. It does create issues, with confidentiality and the adolescent willing to share. So with SBIRT, we'd really like to, have just the students in the school involved. However, but we do recommend when it's intense use and meeting DSM-4 criteria, it is very important to involve a parent. So as I said, this is a more intense intervention than SBIRT. It does involve a parent, and these are students with substance use disorders, whereas SBIRT is really working with a spectrum of use among the students, so that we're trying to identify risky use and prevent it before the student gets to a substance use disorder. Now also, I knew that there would be some attendees from working in juvenile justice settings, so I have another variation on SBIRT here. In a state juvenile correction facility in the Northeast immediately after adjudication, the population were 14 to 19-year-olds who were sentenced to the facility for 4 to 12 months. This was a motivational interview focusing on empathy, developing discrepancy, self-efficacy, and personal choice. And the control group was actually a relaxation training. So, and this is specifically just motivational interviewing. So a 3-month follow-up, the MI group had lower rates of drinking and driving, being a passenger in a car with someone who had been drinking. There was, as I write here, there's similar patterns found in marijuana, but not significant. So as I said, this is not per se SBIRT, but it is a study of motivational interviewing, and the outcomes in this study were focused mostly on driving. Now, the one study here that I found in literature that presents the results of an SBIRT project with a large sample size is this computerized screening and brief advice from the Boston group, Harris. Sion Harris, and the setting was in 9 medical offices in New England and 10 medical offices in Prague, Czech Republic. So there were 12 to 18-year-old patients, and you could see, more than half were from New England. And so this intervention was a program developed really with it was a computer program. The students filled out the screening on the computer, and then there was a printout provided to the physician and the clinician to address the student with some brief advice. So there was some scientific information presented and true life stories of the harms of substance use. And these talking points were really to prompt a 2 to 3 minute session of brief advice. So the findings were significant in that there was less alcohol use found in the New England students and less cannabis use found among the Prague students, adolescents. and there is also a significant effect on initiation. So we're talking that not only is this identifying risky users and reducing use, it's also identifying adolescents who have not used and preventing them from using. So during the 12-month period, there were many that were, there was a lot of prevention of use among those who had never started using.
Oh, Brett, this is Holly.
Yeah.
Can I just interrupt for 1 second and make sure to remind the audience that we're happy to take questions, to you know, answer questions or hear maybe a reflection or a comment. You covered a lot of ground, and I just want to give people a minute to pause and kind of like think. I know you're going to go through the next couple of slides, but as people are thinking about what you just heard, like for instance, to me, I'll selfishly say, I listened when you said parents had an effect in the school setting. I was like, oh, great, because I have a 13-year-old. You know, what are people finding interesting? You could send us a chat or a question in the panel box. Brett could go back to that slide or one of the studies, you know, and we can, you know, just maybe have a few moments of reflection or clarification on anything. So any questions, you can type them up, or if you raise your hand icon, we can try to unmute you as long as there isn't any feedback. And then I wanted to also see, does Tracy, is your audio back up? Because we're going to turn it over to Dr. McPherson at the, in a few minutes, 10 minutes or so. Okay, so, oops, go ahead.
There are a few in the questions box. Would you like me to read those out?
Sure.
Okay. We had one towards the beginning of the session. Currently, SBIRT for youth substance use disorder does not qualify as an essential health benefit under the ACA due to its I score by the U.S. Preventive Services Task Force. What are your thoughts on whether this will become a recommended preventative service required to be covered under essential health benefits as it currently is for adults?
Good question. What do you think, Brett?
Yeah, that is a good question. I mean, we're all, you know, on here pushing for something like that to happen. So, you know, as I said, it's very difficult with to do this type of research on adolescents. And so, of course, there is the I rating. The American Academy of Pediatrics does recommend it. So we're trying. It's really important to try to get some more research and to show these the positive results, so that there is enough evidence. So, you know, one of my recommendations at the end is that we need to disseminate our findings. We need to share this information.
Good point, Brett. I don't know, Tracy, if you want to have any comment on this. I don't have anything specific besides I agree with Dr. Harris that it would be wonderful if, you know, we're all aiming for this, that it would be an essential benefit. There are those prevention codes. They're pretty broad, and sometimes alcohol and drug screening can be put into that. But they're the, are they called the EPD ST codes? Tracy might be able to help me out with that when you come on. I'll look it up, Brett, and maybe we'll go to the next question.
Okay. Yeah, I was going to say, Holly, this is Tracy, that I agree with both of you. We're very like-minded here. That I really think we do need to produce more research, good, sound, quality research, and what's out there needs to be published, which takes a lot of time. And if it really does take 17 to 20 years to actually move things into publication and then to practice, I think we've had probably a little bit of time. We've, 40 years is quite a long time, but I think we still need to get more out there before it's going to be pushed to the point where it would be an essential benefit. So publish good quality studies.
Yeah, and just to close the loop on the code, so there is an EPSDT billing code for Medicaid patients, and it's sort of like a code that, is for well visits, in which you could, put in that you think that, let's see here, I'm looking at the code, if there's like a screening code for prevention, and I do know that there are some grantees looking at those codes in various states as a means of, getting it in, more broadly, more essentially as a priority area. But it's definitely not to scale. So if it was as an essential benefit, that would bring it to scale, and we do need the research to help inform the policy. So
yeah,
I don't know, again, go ahead. Oops, go ahead. Is that Tracy?
Our experience, too, in doing technical assistance with a variety of organizations is that that seems to be the place, the EPSDT codes seem to be the place, and the well visit, or sometimes they call them well check visits. They call them different things, I think, in some different states. But essentially, that's where they're integrating it for anyone under the age of 21. That's been what we're seeing.
I see. Thank you, Tracy. So Danielle, there are a couple more questions. Maybe we could, and then we'll get back to Dr. Harris's presentation. But, you know, we think audience engagement's important, too, for sure.
There are a few more. Next up is, what is your response to the recent studies in JAMA questioning the efficacy of BI for substance use disorders?
Yeah, that's. I think you're referring to the studies I mentioned earlier on the in the presentation, States and Roy Burns articles in JAMA. So these were for drug use, and for among adults. SBIRT for drug use is not, it has the I rating, incomplete or insufficient evidence to recommend this. And what SAMHSA came out and said was that it doesn't have anything to do with the efficacy of the screening. So we still, even if it didn't work in this particular setting, that this screening for drug use does identify and have positive impact for these drug users, and they can get the specific referral to treatment. And I think, too, that if you're going to be doing SBIRT, for alcohol, that it's the same. It doesn't really take much more effort to include the drug use as well. And, as the argument is on the other side, these were this is primary care settings with very high-risk populations, so we would need to do, of course, some more studies to see whether this works, in other populations and more, traditional populations.
Well, this is Holly real quick. We feel like we welcome the research. We just said that to answer the previous question. We need more research. So we want research that challenges us so we know what is effective in what settings with particular populations. But on the other side, this is a health and wellness intervention, it is a public health model, and especially in particular settings like schools and like hospital settings, primary care settings, in which this is building a relationship with the person that you've screened, and if they're using any substance in a risky way, you could make that health and wellness connection for them, that it's actually ethical and morally responsible to say, have you reconsidered, your weekend use of marijuana might be holding you back from making the track team. And that, we want the research, but at the same time, we need to apply some practical application of it in the settings that we're using it in the context of that situation to improve a patient's health and wellness or their, social status and well-being in a school setting or a variety of settings that we kind of touch base on.
Yeah, and Holly, this is Tracy. I would add that you hear that perspective also when you're working in other areas where health promotion and wellness is important, whether it's through occupational health or health and wellness programming or employee assistance programs. It's a safety issue, and asking about substance use. Yeah. And it's tied to a lot of things around productivity and absenteeism and so forth. So, yeah, I agree. There's a lot more research needs to happen, but certainly from a very common sense perspective in some of the workplaces we work with, it seems to make sense to ask about these things as it impacts a lot of aspects of people's lives.
Okay, Danielle, we have one more quick question, then we'll go back to Brett?
Okay.
I see there's some questions. I don't know what you want to do.
When implementing SBIRT in a health clinic, how often should the screen be done? Doing it once a year seems counterproductive with using adolescents.
Yeah, And it varies too, because in the projects I've worked on, we've done it, every 6 months or even every month. So, it really does help to have it, when the student or an adolescent comes in, every time the adolescent comes in, if it's not, like every couple of weeks, if it's, a month or 3 months to 6 months, and because, a lot can happen within 1 year. But, we do like to say universal screening. So when the student, the adolescent comes in, it's very important to conduct a short screen. But, if you schedule an adolescent to come back in, in 2 weeks for a specific item, it doesn't need to be covered again. But if it's, coming in, at a decent amount of time later, we definitely suggest to rescreen at that point.
All right, why don't we pick up with Brett's presentation, and then, we will revisit some of these questions. And if we can't get to all of them, what we can do is collect them from our questions panel, and we can email out general answers. Thank you, guys. See, that made it engaging.
Yeah, so some good questions. With all of this research that the American Academy of Pediatrics as well as the American Medical Association do recommend that this is done with adolescents, so pediatricians and other healthcare providers, and that they should also be ready to refer adolescents to outside treatment providers if necessary. So what is actually happening? And we talk about that translation of research into practice. Right now, fewer than 50% of pediatricians are actually screening their patients for substance use, and there's also little use of standardized screening tools, so tools like the CRAFT. This unfortunately leads to a failure to identify the risky users. One study found that using the adolescent diagnostic interview versus clinical impressions. So whether the the clinician thought just off from what he sees if this adolescent has a substance use problem. So what was found was that of the 86 adolescents that actually exhibited abuse or dependence, the providers classified almost a quarter of them with no use, 50% with minimal use, 15% with problem use, 10.5% with abuse, and none with dependence. So, this is an issue that a lot of the adolescents will be missed without the use of the standardized screening tools. There's also inconsistent, meaning non-universal screening happening. So some types of adolescents are screened more often than others. For example, older adolescents or males may be screened more often than younger adolescents or females, and also not using the more effective counseling strategies. Now, a study that I recently completed, so I'd like to put my plug in here for my study, was of clinicians in New York State school-based health centers. So what are they actually doing? As you can see here, 50% of them don't practice any part of the SBIRT model in their school-based health centers, and we have only 11% practicing the full screening, brief intervention, and referral to treatment model. What was also found was a variation in practice. So some parts of the model are conducted more often than others, and the ones conducted least often would be using the standardized tool, assessing readiness to change, and providing the referral to treatment for the students who are suspected of having a problem. Now, why is SBIRT not being practiced? So there were various studies that identified some reasons. Mainly time constraints, lack of training, not knowing what to do with a positive screen, the perception that adolescents will not tell the truth about their use, though some studies have found that they actually are willing to share this information, as well as many evaluations of projects. Perception that it's not their role to address substance use, rather it's actually they would refer the student off to a substance abuse treatment provider. Low self-efficacy for helping students on this, and low perceived effectiveness that actually what they're doing is helping students to reduce their substance use. And then not believing that screening will result in early intervention or positive outcomes for the adolescent. So, in conclusion, so what are we doing, next steps? So we're all here together in this learning community, and of course we want to learn from each other. We're in different settings, we're in different steps for implementation, and it's really helpful to all get together and discuss this, which we hope to do in future sessions of the community. So we also need to develop methods for effective dissemination of SBIRT to increase the awareness and to promote its adoption as well as its implementation with fidelity. So we need to target our efforts also based on the audience that we're presenting to. And then to share our lessons learned. So we need to conduct research and evaluation, and we need to share this information. So in presentations, conferences, and webinars, we want to publish this information and share it with a wider audience. As Holly mentioned before, we are going to continue with this learning community in this fashion for the next couple of sessions. So we have an upcoming webinar in March on screening tools for adolescents, and then one coming up in June on case studies of programs that have implemented SBIRT. And in the future, we do hope to get some information from you guys on what you would like to discuss, and then have more interaction. So at this time, I'd like to hand over the presentation to Dr. McPherson.
Thanks, Brett. And I see you have a lot of great references there that folks are going to be able to take a look at, and looks like you very generously provided your email and phone number in case folks want to follow up with you. I also am glad to talk to anybody. I have, we can make my email and telephone number available as well. So thank you. So Danielle, if you want to move to the next slide, you don't need to transfer it over to me. Well, thank you, folks. I really do appreciate the opportunity to tag on at the end of this terrific presentation, Holly and Brett. There's a lot of terrific information in here that will really be very useful to a lot of the folks on this call, and also to our learning collaborative that I'm going to just mention very briefly. As NORC at the University of Chicago is a partner to the National SBIRT ATTC, and we are trying to do our part to promote screening and brief intervention for adolescents and young adults. And we have a new initiative, a new project funded by the Conrad Hilton Foundation called Integrating Adolescent SBIRT Throughout Social Work and Nursing School Education. And really our overall aim is to collaborate with you, your colleagues, to move this kind of information on the research, on the practice, into the mainstream of education for...
Oh, Tracy, can I interrupt you? I don't think we're seeing the right slide. Do you want me to show it, Danielle?
If you don't mind, it
problem.
wasn't allowing me.
Well, we enjoy seeing the picture of your wedding, though. It's very pretty.
Sorry.
Send it over to me, and I'll do it. Tracy, that way they can be following along. Okay.
Great. No problem.
Danielle just got married, everybody. Didn't they look so beautiful? All right. Here we go. So, Danielle, let me know. Are we seeing the right slide, partners?
Yes.
Okay, no problem. So there's Dr. McPherson's contact information and the exact title of the project. And then, Tracy, you were talking about the aim, so we'll hand it back to you.
Yes. And in fact, if my email is my last name and hyphenated my first name at norc.org. And it's not on that last slide, but certainly I put some other contact information to our research assistant who is helping me manage the project on the next slide. So anything that you, if you are interested in learning more about the work that we're doing to infuse adolescent SBIRT education into existing curriculum within schools of social work and nursing, we have a learning collaborative that we are launching this month. We've actually just launched it, but there is still opportunity to be a part of it. We have our next call is February the 10th. It's from 3 to 4 in the afternoon Eastern Time. If you're interested in learning more about it or would like to participate in the Learning Collaborative, you can email Danielle Noriega at NORC, and her contact information is at the bottom. And we have launched a website. It's sbirt.webs.com, where you can actually download a brochure about the Learning Collaborative, and you can download additional information about the technology that we're going to be using to develop the curriculum. It's a technology available through Cognito Interactive. It's an interactive online patient-client simulation training program that the end user is actively engaged in a learning process and gets feedback along the way. We put a link up to a sample of what that technology is, and we also have a lot of other partners as well in social work and in nursing who are working with us to launch this. So thank you, Holly and Brett, for giving me the opportunity to share information about it. And I hope folks who are interested, who are from schools of social work and nursing, are interested in Learning Collaborative, will contact us and get involved.
Well, thank you, Tracy. And I see we have some questions. What do we have, like 2 minutes? Maybe we can get one question in, and then the rest we'll have to just circulate, Danielle, between myself, Tracy, and Brett in an email. We can put together some answers and then email that to the group.
Okay. The earliest one asked was, if the setting has the ability to deliver multiple sessions of between 45 to 60-minute sessions, would you suggest Teen Intervene be used?
Oh.
That's a good question. I'm not an expert on Teen Intervene, so I wouldn't want to answer that. Teen Intervene, in Ken Winter's studies, has some, positive impact. So, I'd refer you to that study that I presented, and you can look at the pros and cons of doing each.
Yeah, and I would be glad to share a link with you, Danielle, on the Teen Intervene program and where you can get manuals on that. I also would like to offer folks on April 15th from 3 to 4:30 Eastern, we're going to have Ken Winters talking about his Teen Intervene program as a part of our Learning Collaborative, and anyone who's interested in being a part, attending that can email Danielle, and we'll get you information.
Yeah, in fact, what we could do, Tracy, is send that registration information in this email blast with the PowerPoints for people. Is that okay?
Oh, that'd be great. Thank you.
That was a good question and a very good segue to that webinar. I have the top of the hour, Danielle, so do you want to have any final remarks about last logistics?
Just for everyone to keep an eye out, there will be the follow-up emails with the PowerPoints as well as some additional information. There were questions we unfortunately didn't get to, so we'll get you some responses and send those out to everyone.
This is Holly Hagel. My final thought is please return in another month to the next learning community. The beauty of the community is if we have return people attending, so we can start building, a coalition of the willing, or those who believe in SBIRT for youth. And, we will post that webpage together, and we will, be communicating with you to let you know of other opportunities. So thank you for joining us today, and you have a great rest of the day. And if you're on the East Coast, take care.
Thank you, Holly.
Bye, everyone. Thanks.
Thank you.